Hi, my name is Jim Hillcoat. I'm with the Crosse Fire Department, and today we are here doing a demonstration on how pre-hospital EMS and first responders approach fall victims. Falls are one of the most common causes of injuries in the pre-hospital setting for the older population or the geriatric population, and we're going to do a demonstration on how we approach, assess, and treat these people in the pre-hospital setting. Right here I have a victim. My victim's name is Matt for the scenario today. Matt had a fall. Possibly tripped over something or had a medical incident that resulted in a fall. As a first responder, we immediately approach the patient, and the first thing that we do is we're going to assess their mental status, and that will give us a really good indicator of the severity of the patient's condition. So right now I have a conscious patient. This patient is talking to me. They have normal mental status. They're fully aware of their surroundings, and they are able to talk to me and tell me exactly what happened here today. So while I'm getting a medical history and all of the events leading up, I'm going to actually start my physical assessment of the patient. We're off to a good start due to the fact that I have a fully alert patient with normal mental status. So that tells me that right now they're completely stable. I'm going to go ahead and look at the patient's head. I'm going to feel and look for any injuries, assessing his airway, his breathing, looking for any bleeding, any signs of injuries such as hematomas, or cuts or lacerations. I'm going to check his head, eyes, ears, teeth, nose. Nothing noted here. This is going to be a very basic, straightforward patient with an isolated hip injury. As I work down the patient, I'm palpating the patient all the way down. The patient's going to let me know if they have any pain. I'm also going to note if I feel any deformities or note any bruising. I'll expose the patient as I need to look for signs of injury, whether internal or external. I'll work my way down to the hips. I'll palpate the hips and look for a problem here. In this scenario, I have revealed that the patient has significant right hip pain. They have pain upon palpation. I've also noted that his foot is turned out down here and shortened, which is a clinical sign of possible hip dislocation or fracture. So that is noted on my assessment. I move down. I check the patient's circulation by having them move their toes, having them tell me that they can feel what I'm doing. And that gives me a good indication that they have good circulation or peripheral circulation to the extremities. Now lastly, I'll go up to the upper extremities, the arms, and I'll evaluate for any injuries there. In this scenario, I do not have any. At this time, I'm going to have Firefighter Harris come over. And Firefighter Harris is actually going to hold the patient's head and keep the patient's head in line. This is called manual spinal immobilization. In our pre-hospital guidelines for first responders, in this situation where a patient has had a fall, and due to the patient's age being in the geriatric sector, we would likely have a high index of suspicion that they could possibly also have a cervical injury or back injury. Thus, we will not be able to clear this patient from exclusion from those precautions that we'll take. So Tyler's going to hold the patient's head. Firefighter Lindahl is going to place a cervical collar on the patient. And this way the patient is going to have some immobilization up there until we're done with our further detailed assessment. But now we are moving into the phase of packaging the patient and performing any other interventions that we need to do. Now prior to moving to this patient, there are some things that we can do for a hip injury to minimize pain, to minimize movement. So I'm going to have Firefighter Lindahl place what we call a well splint. A well splint is a splint that will actually just fill this gap between the patient's legs. We'll tie their legs together. This will immobilize the lower extremities, further immobilize the hip, and create less pain when we have to move the patient. So I'll give Firefighter Lindahl a moment to do that. Throughout this entire process, we're always maintaining vigilant contact with the patient, continually assessing their mental status, their pain scale, reassessing and reassessing constantly, because we never know when there could be internal bleeding or other underlying things that we're not aware of that we would need to address. We would get a set of baseline vital signs to include blood pressure, pulse, count their respirations, collect any other significant medical history, a list of medications, any known allergies, so that we're prepared to administer pharmacological intervention for pain management if need be, or if it's determined that the patient wants it and we have it available. And then from that point, we will transfer this patient to a transport service. In this case, Tri-State Ambulance will be arriving shortly, where we will give off a patient handoff report. We will transfer primary care, and then we will prepare to move this patient from this location here onto a stretcher and into the ambulance so they can be transported to the facility of choice for the patient or the nearest facility. So we have our well splint applied. We have cervical spinal percussion immobilization in place. We are ready to now put the patient on a rigid spine board or a backboard or a combination board. We have multiple names for it. So you can see firefighter Lindahl here is going to prepare to place that. At the La Crosse Fire Department, we have a combination board, and there's great advantage to this because we can split the board and put it back together instead of having to roll the patient possibly onto an injured extremity, causing more pain. So we find these boards to be beneficial and easier to place and with less manipulation of the patient. Are you ready, Jay?
Ready.
Okay, so we're going to go ahead and slide this up. Okay, you want to go ahead and lift the legs together. And again, continuously communicating with the patient, keeping them informed as to what we're doing, why we're doing it. Okay.
Farther. Good. Anything hurt? No. Okay.
And we can go ahead and both start moving these inward. Nice and easy, nice and slow. I want to avoid pinching the patient at all.
All right, you're here.
So we're to the point now where we'll have to lift that side there just gently.
Yep.
And the patient always in this case is the patient care is being led by the person holding the head at this point because they're the most important to make sure that we're keeping the head and neck in line as we do any manipulation of the patient. Go ahead.
3, 2, 1.
Okay, I think we're good.
Down.
Okay, now we'll do the other side.
Ready? 1, 2, 3.
Firefighter Harris gave the cue, and we get the cue to go back down. Looks like we might be just a little high, but our patient is a little tall, but I think this will work, okay? This will work because we're going to be moving this patient to an actual stretcher off an ambulance, and where we'll actually be removing the board. Okay, so Firefighter Lindahl will finish securing the patient to the rigid board. I now have Todd from Tri-State Ambulance arriving on scene. This is the point where, as the first responder service, we'll go ahead and give a detailed report about our findings and what we have done, and we'll transfer primary care and move on from there. Hi, Todd. This is patient Matt. He had a fall today, no loss of consciousness reported, isolated right hip injury with significant pain noted. No other findings on evaluation. His mental status has been good throughout. His pain scale has been consistent. No signs of bleeding. He has no significant medical history and is not on blood thinners. Reports no allergies known to medications. He's requesting transport to Gunderson Health System today. As you can see, he's been fully immobilized with spinal precautions in place. We would be ready for the stretcher. Okay. All of these tools you see in front of you between the backboard and the stretcher are major assets to pre-hospital EMS. They've come a long ways with technology. As you can see, the stretcher here is actually a powered cot. It wasn't that long ago where we had to manually lift these, causing a lot of injuries to pre-hospital providers. So it's really been neat to see the evolution of EMS equipment, patient movement equipment, as time has gone on over the last 20 years. It's become safer for the patient, safer for the provider, and made our jobs a little more safer for sure. Okay, so Todd's going to man the stretcher. This is a typical way that we would lift the patient and transfer him to the stretcher. Again, patient on the head, holding the head, is going to call out the movement.
Are you guys ready? 1, 2, 3.
Okay, it looks like we got to get centered just a little bit.
1, 2, 3.
Okay, looks good. We have the patient centered on the stretcher now. We're going to go ahead and, we're going to go ahead and prepare to move the backboard. Now this is also something a little bit newer to EMS, is actually taking the patient off the rigid board. It wasn't long ago that we would actually transport all patients with suspected back or spine injuries on backboards. They're very uncomfortable. They're actually not anatomically correct. And finally, after a lot of data coming through and evidence to support it, we have new guidelines that allow us to take the backboards off and actually transport them on the stretcher with other immobilization precautions in place. So this has been good, especially with the geriatric patients who would be more uncomfortable than maybe you or I on a backboard.
We'll take my side out first, Jim.
Okay.
If you want to hold him, roll your way slightly.
1, 2, 3.
With very little manipulation, we can take this board off, and that's really good. We're going to cause less pain for the patient and protect their cervical spine if there did happen to be an underlying injury we're not noting right now.
Ready, 1, 2, 3.
Very little manipulation with the combination board. So now we'll go ahead and secure the cot straps, put the side flaps up, and we're ready to load for transport to definitive care. Again, reevaluating my patient, constantly talking to my patient, noting any changes, addressing any changes. Now, one final intervention before I'm able to release Firefighter Harris from holding the patient's head. We're going to go ahead and put what we call a immobilization collar on. It's basically a homemade collar using a blanket roll. And there are other ways to immobilize the head. We've had what we call SIDS, or cervical immobilization devices. Those were typically used with backboard devices when we are actually going to keep somebody on a board. Realistically, the only patient we're going to keep on a backboard is one where there's a very, very short transport to the hospital, or one where there is multi-system trauma and we use the board as a full body splint. In this case, I have a isolated hip injury. We're going to go ahead and place this horse collar around the patient. Firefighter Harris is going to gradually lift the head. There you go. Letting the patient know what I'm doing. I'm going to tuck this under their armpit. Go ahead and rest your arm. Go ahead and rest your arm. Keep your arms crossed. You can go ahead and release. All right, this is acceptable full immobilization spinal precautions for our pre-hospital guidelines. So let's finish putting straps on, and we'll move them to the ambulance. And I reevaluate my patient after every intervention. As the first responders in our system, our care isn't done yet until the ambulance leaves the scene. Often we'll assist the transport agency with further patient care in the ambulance, whether that be establishing IVs or any other interventions such as medication administration for pain management, or adjusting any of the current interventions. But from this point on, Tri-State Ambulance will continue reevaluation of the patient during transport, give report to the receiving hospital, and the receiving hospital will prepare for their arrival. More than likely, this patient will end up getting an x-ray of their hip to determine whether there's a fracture, dislocation, and the patient will move through the chain of hospital care from there. That's been the La Crosse Fire Department's demonstration of pre-hospital assessment and care of the fall victim. We hope that was informational. Thank you.